I met Dr. Bob Sise when he first came to Helen. It was right at the beginning of the pandemic. He was there with his partners at Frontier Psychiatry, and we sat around in a circle at the park outside of the NAMI, Montana office and talked about this amazing new telepsychiatry platform that they were bringing to Montana. And, you know, Dr. Sise's academic credentials are top notch. He's done everything, he helped start the EmPATH Unit at Billings at the Billings Clinic. He was working on the psychiatric residency program. So there was all of these things. And then I heard he was an addiction psychiatrist. And it was just like somebody telling me that Sasquatch was sitting there, you know, like to actually have a real addiction psychiatrist there to be able to talk to and ask questions. I basically didn't pay attention to anything else and just started pestering him with questions for the rest of our meeting. And that was the genesis of this webinar. I was like, I have to bring Dr. Bob Sise to the NAMI, Montana audience. So this webinar is sponsored by the Addictive and Mental Disorders Division of the Department of Public Health and Human Services. We are having this instead of a conference this year, but this is just a great example of why we're so excited to be able to spread information like this around the state. So please join me in welcoming Dr. Bob Sise.
Matt, thank you so much. You're too kind. I have a lot to live up to now. Pull it off. Fingers crossed. So I'm going to start my screen share. This is a talk I've given a few times in various different variations. I think we're going to have more fun today than we usually do. And, you know, really encourage participation, questions. Matt and Colleen, if you want to interrupt me, as questions, comments come up, please feel free to do so. I think keeping this as interactive as possible is going to really make it resonate. Cannabis is recreationally legal here in the Treasure State. That said, the sale in a recreational manner is yet to start. That's coming online this January. And we're already seeing a lot more cannabis. There was a lot of use to begin with, flashing back 2-3 years ago. It's increasing ever more so. And unfortunately, a lot of patients view it as benign. We're going to talk about the evidence linking cannabis use to virtually everything else psychiatric. And ideally draw from this things that we can share with patients and talk about how it can be meaningful to discuss this data with patients, friends, and family members. So I am one of the co-owners, founders of Frontier Psychiatry, as Matt mentioned. That's my only disclosure. We will look to appreciate how cannabis use disorder is associated with other common psychiatric disorders, understand the evidence for the deleterious impact cannabis use has on mental health overall, and identify potential interventions as well as forms of treatment for cannabis use disorder. So I always like having a case because I think it always makes it a lot more salient and really helps connect to have someone in mind. And so I invite you to think of maybe someone you know who consumes cannabis on the regular, maybe experiencing similar issues to this kind of somewhat imagined, but also very realistic patient. This is Miss AP. She's a 27-year-old woman who comes in a clinic. She's working part-time at an event management company and is completing her bachelor's degree online. Her past psychiatric history is remarkable for being prescribed methylphenidate, which is a prescription stimulant, when she was a child. She says she definitely had ADHD. She has a history of childhood sexual and physical trauma, longstanding depressive as well as anxiety symptoms, and reports that she's tried several SSRI antidepressants like sertraline, fluoxetine, so on and so forth, and they all failed. She oftentimes feels depressed, deals with a lot of anxiety, and is experiencing intrusive memories of past trauma. She says she smokes 1 to 2 joints nightly to help her sleep and decrease anxiety. She's not taken any medications whatsoever, insisting she prefers natural substances. But she's now requesting a medication, acknowledging that her weed use isn't enough to treat anxiety, PTSD, and depression. So this kind of question and the options have a clinical focus, and we're not going to dwell too much on it and just jump straight ahead to what I'd recommend, and that's really engaging this person in motivational interviewing, targeting cannabis use reduction, ideally stopping it. Motivational interviewing essentially refers to finding a way to unearth the patient's narrative of what the substance means to them in really the truest way possible, having them sit with the ambivalence. A lot of people have mixed feelings about their substance use. They do it because it gives them something, otherwise they wouldn't do it, but oftentimes they're at least in some way, shape, or form aware of the cost that they incur insofar as impacted function, worse physical and mental health. Motivational interviewing engages that and then helps build the patient's change narrative of how they're going to change and ideally reduce, if not eliminate, use. Gabapentin is really all we have for medication-assisted treatment for cannabis use disorder. And this last point I emphasize because I think this is just part of being a good clinician. You're going to want to treat everything co-occurring. And there's really no evidence whatsoever in waiting to treat depression, anxiety, or trauma-related symptoms, waiting for someone to be abstinent from cannabis. You should treat even if they continue to use. Any takers on what movie this photo is from and the actor? Anything coming up in chat? And Matt, if you could help out, or Colleen, because I can't see the chat right now.
Nothing yet. All right. All right. We got one. They're just getting started though.
Okay. Hopefully people are tuning in. It's not reefer, Matt.
Dr. Strange.
Yes, Dr. Strangelove. Excellent.
Peter Sellers.
Yes, wonderful.
Mark Piskowicz on that one. Nice work.
So this is kind of like very, very tangential, but if you bear with me, I think the humor here applies because it's a movie where there's a ton of absurd misunderstandings between the Soviet Union and the US. It was a 1959, 1960 film. And what's I think resonates for this topic is we so often are stuck in really absurd conversations with patients, loved ones about their cannabis use, in which we may as well almost be speaking different languages. And while a nuclear holocaust isn't at stake, significant effects on mental health are at stake. And so it's worth to find a way to connect the evidence with the people we care about. When we talk about cannabis, we are referring to the plant Cannabis sativa. 85 different cannabinoids have been derived from Cannabis sativa. The two that we're most principally concerned with are cannabidiol, CBD, and delta-9 tetrahydrocannabinol, THC. There are various different strains of Cannabis sativa out there, and they have varying concentrations of CBD versus THC, acknowledging that the jury is still very much out when it comes to CBD, cannabidiol. Here in the US, as most of you are aware, cannabis is not federally legal. That limits the amount of research that we can do. In a sense, we're not doing really any sort of significant research to scale in comparison to countries like the United Kingdom and elsewhere where cannabis is legal for medical purposes. Cannabidiol likely has some immunologic and anti-inflammatory effects, and it's actually a very, very low potency antipsychotic. Certainly could not replace a standard antipsychotic. Contrast that to THC. It acts differently. It's a different type of agonist, different type of receptor activation profile, very psychoactive, and this is what gets people stoned, and what kind of in pop culture we refer to as the high, causes alter mood and impairs cognition. We'll get into that a little bit more. It's worth emphasizing that in spite of the fact that you have these two different cannabinoids with different profiles and really different effects, across the board, and this data is from a presentation from one of my former co-fellows in the Addiction Psychiatry Fellowship, Kate Reen, It encapsulates how over the 20 years from 95 to 2014, the THC concentration in all-comer cannabis, and at this point it would be purely medicinal, right? Because it didn't go legal in Colorado and Washington for recreational purposes until 2014. You can see that virtually a threefold increase, a tripling in the THC content. And that is matched by the CBD content falling in by nearly a half over that same interval. So our patients, our family members, people we know using cannabis, more often than not, no matter what they are what they think they're getting very high THC content product. And it can be even, in some cases, hyper concentrated, depending on how it's used. A lot of people smoke cannabis, a pipe, a tobacco water pipe, can roll it in a joint, a fat joint, a blunt. They can vape it, mix it with tobacco. Edibles, big take home here is the effect is delayed, oftentimes as long as 2 hours after ingestion. And there are concentrates. And here's where we get into some of the higher incidence of cannabis-induced psychosis, in particular, butane hash oil, dabs, wax and shatter depicted here. And they can have up to 80 to 90% THC concentration. When it comes to cognitive function,
Bob, we had our first question come in, and it's from Jessica Heidi. She's asking, what does MAT stand for?
Great clarifying question.
As MAT for
great clarifying question. Thank you so much. So MAT is kind of the shop acronym for, sorry, it's my pager. It's the acronym for medication-assisted treatment. It means a medication we can use that is evidence-based in helping people with a substance use disorder to either at least cut back their use or ideally abstain from use. And we'll talk about gabapentin here in a bit, time permitting. So question here, and participation would be great. Let's see what y'all say. For cannabis use and cognitive function, which of the following statements is true? Acute cannabis use is associated with impaired cognitive function in several domains. Chronic cannabis use beginning in adulthood results in permanent cognitive impairment. Chronic cannabis use in childhood or adolescence results in permanent cognitive impairment, or all of the above. Any takers? Let's maybe wait 20 seconds or so and see what we get.
We got 1 and 3, but I bet you were going to say 4. 1 and 3 and 4. 4.
I like it.
4.
All right. So
4.
People are taking this seriously.
1.
Awesome. Let's check out the data. So we know
All the above.
there's very compelling and consistent evidence for both acute as well as long-term cognitive impairment associated with cannabis use. In a dose-dependent manner, cannabis acutely impairs attention, concentration, episodic memory, and associative learning. And this most closely tracks the THC dose that people are getting. Higher THC, more impairment. Long-term cannabis use is associated with impaired verbal memory and also cognitive processing speed. It's worth noting, though, both of these impairments generally resolve after about a month of abstinence. So that's really good news, right? Especially for our patients who start their heavy cannabis use in adulthood. If they stop it, they can see really a restoration of their premorbid cognitive functioning. Chronic cannabis use that starts in adolescence is associated with a lower IQ score and permanently up to 8 IQ points lower in comparison to a cohort that doesn't use. And this is even after patients engaged in sustained abstinence. So the study this comes from, it's worth noting, they acknowledged there were so many confounders, meaning there were so many other things going on that could have adversely impacted these kids. Specifically, they didn't control for childhood trauma, for other psychiatric issues. And if you think about everything else that could live with early childhood exposure and early adolescent exposure to cannabis, there's a lot there that can also adversely impact IQ. So the jury's out, but there is this general association.
we had a question come in. What would you say to people like Carl Hart that say that the curve on adult memory loss goes down with continued use, that people adapt to using?
So you can see neuroadaptation with virtually any substance. Be that as it may, we know overwhelmingly, if you take the same person absent of cannabis and take that individual, expose them to THC, we're talking 5 to 10 milligrams a day. Standard joint, if there is such a thing, is probably 5 milligrams in the US. They're going to be slower on a variety of metrics, including verbal recall. And that is a fact of how THC works. It globally impairs cognitive function. So here, the first statement has a lot of evidence supporting it. For 2, we don't see that you have lingering cognitive impairment if you can abstain. For 3, the jury's out. Again, there are way too many confounders in that cohort of kids, adolescents who started early cannabis use. We're unsure to attribute the lower IQ to cannabis use versus everything else that they may have been exposed to. How about cannabis use and mood disorders? And by mood disorders, we're talking bipolar, so the high ups that can erupt into mania with psychosis, and the desperate lows of depression can sometimes have psychosis, versus just depressive disorder, which is just down. So cannabis use and mood disorders, which the following statements are true. Cannabis use is associated with higher severity of mood symptoms in depression and bipolar disorder. Cannabis use is associated with lower rate of major depressive episodes. There is no increase in the rate of cannabis use disorder in patients with bipolar disorder versus the general population, or all of the above. So let's contemplate that. For these questions, the answer is going to come at the end. It's kind of to prompt us to focus in on the evidence. It can get a little bit dry, but I think there's some cool takeaways we're going to go over. So when it comes to cannabis use and all-comer mood disorders, there's a significant association. From a 2011 secondary analysis that included over 40,000 US adults, there was a 2 to 3 times higher rate of lifetime cannabis use among patients with depression or bipolar disorder versus folks who didn't have a mood disorder. In a 2018 systematic review, it was discerned that recent cannabis use, meaning during the 6 months prior to assessment, was associated with higher intensity of mood symptoms during subsequent follow-up from 2.5 to 5 years out. When it comes to cannabis use and depression, there is a significant association here. From a 2014 meta-analysis, saw that heavy cannabis users were significantly more likely to have a major depressive episode versus light or non-users. It remains unclear as to whether or not there's a causal link here. Can comment on how twin studies support the hypothesis that a comorbidity of cannabis use disorder and depression is likely due to both genetic and environmental factors predisposing to both disorders. For cannabis use and bipolar disorder, again, significant association. Lifetime rate of cannabis use disorder in bipolar disorder is roughly about a third. That's super high, given in the general population, it's just 1.5%. Acknowledging this isn't just any cannabis use. This is the combination of physiological dependence on cannabis, as well as all of the impairment in function, be it work, home, and adverse impacts on health that are necessary to meet the diagnostic criteria for cannabis use disorder. So it's a big deal. Significant association between cannabis use and both earlier age of onset of the first manic episode and more frequent mood episodes, more cycling. Cannabis use was also associated with a 3-fold increased risk for new onset of manic symptoms. So the evidence here strongly indicates cannabis use is associated with a higher severity of mood symptoms in depression and bipolar disorder. Again, association, not necessarily causation. We, to date, have not been able to do the kind of deliberate research that would allow us to establish a clear causal link. Although there are many who hypothesize and argue that cannabis use likely triggers a worsening of depression and worse and more frequent manic episodes. How about cannabis use and psychosis? Another 4 options here. Cannabis use is associated with a higher lifetime prevalence of schizophrenia. Various case reports demonstrate an association between the use of high THC content products and psychosis. Onset of cannabis use in early adolescence is associated with a significantly higher lifetime risk of psychosis, or all of the above. If we want, I think we're doing all right for time. And Matt, keep me honest, are we targeting kind of 40 minutes or the full hour? What kind of timeline do we have?
We would love to do the full hour.
Okay, great. Yeah.
And we did get one request for less questions and just asking you to blaze away and do questions at the end.
Okay, totally fair. We can do, well, then we'll know the answers. Pay attention.
Yeah, right now we've got a ton of 4s, a couple of 1s.
Okay.
A couple of
awesome.
2s.
That's good. That's good. Cool. So people are contemplating this. I like it. Cannabis use and psychosis, significant association. From another systematic review that included over 50 studies of patients with schizophrenia spectrum disorder. So this is people who have some form of psychosis. There was over a 20% prevalence of cannabis use in the 6 months prior to the assessment, and over a 40% prevalence of lifetime use. When it comes to cannabis-induced psychosis, there is a clear association with higher THC concentrations. Case studies demonstrate general association between the use of high-dose THC products, think the wax and shatter, in which you're getting mega doses, sometimes 20-fold what the common joint would deliver. Association between the use of that form of cannabis and cannabis-induced psychosis. The most compelling explanation of how this works comes from our understanding of the dopamine pathway. So dopamine is essential, sorry about that, another page. Dopamine is essential for not only reward in the immediate sense when it comes to food, sex, drugs, alcohol, social belonging. One step further, it turns out it really helps us discern salience. So it helps us figure out what we're going to focus on at any given moment. It's the lunch hour. You're probably, if you're not eating, you're probably wondering about what you're going to eat or regretting having not packed the lunch. Deciding whether or not, okay, am I going to listen to this guy or kind of focus on what I'm going to eat? You're constantly engaging between discerning, am I focusing on external stimuli or internal stimuli, my internal dialogue? The dopamine pathway helps regulate that. When it goes haywire, when it's overactivated and overexcited, as is in the case of schizophrenia, that mechanism of discerning salience goes away. And all of a sudden, imagine if your internal dialogue had the same level of meaning, the same level of importance as somebody yelling in your face. It's a nice exercise in empathy to help understand psychosis, to really think about it in those terms. Why does high THC content product provoke psychosis? Very likely because THC is dopaminergic. It makes the same dopamine pathways in the brain that in many ways are overexcited in primary psychosis. It causes them, in folks who may not have primary psychosis, to be overexcited. And if they have psychosis to begin with, it can worsen the severity thereof. It's unclear whether this acute effect, though, is related to the development of schizophrenia associated with chronic cannabis use. So clear association here. In a Danish study that looked at a national registry of about 1,500 patients who received the diagnosis of cannabis-induced psychosis from 94 to 2014, and then they were followed through the end of 2014, they found over a 40% conversion rate to schizophrenia, suggesting that people who have cannabis-induced psychosis are at higher risk for schizophrenia. Now, is it because the cannabis use unleashed or advanced a primary psychosis that would have unfolded regardless? Is it that exposure to high doses of THC potentiated the dopamine pathway, making them higher risk for psychosis subsequently? Or is it a combination thereof? We're not sure, but there's an association. For cannabis use in schizophrenia, strong association. Here it's a cross-sectional study that indicated regular cannabis use was associated 2 to 3 times higher lifetime prevalence of schizophrenia in comparison to non-users. Schizophrenia was strongly associated with an earlier age of onset of use of cannabis, higher frequency of use and amount used, and use of products with high THC to CBD ratios, which, as we saw, is increasingly the norm across all forms of cannabis that are available for consumption.
Bob, we did have a question come in about the Danish study and
Yeah.
whether age mattered in that one.
I did not see that comment, but hold that thought because we're going to look at another study that addresses that.
Okay.
In a systematic review of 35 longitudinal studies, Moore and co-authors found there's an increased risk of psychosis associated with any lifetime use of cannabis. Again, we're now seeing this emerging association that's replicated again and again in studies. Dose-response relationship, in which a twofold increase in the risk of psychosis among the highest frequency cannabis users. And here is where let's focus in on the relevance of age of onset of use. So in a Finnish prospective longitudinal study, so far study designs, that's pretty good. It's not a randomized control, but hey, it is prospective and longitudinally designed. They saw significant risk of psychosis among the subjects who use cannabis at least 5 times by the age of 16 versus those who had never used. These were 6,500 Finns who were born in 1986. They were evaluated at age 15 and age 16, evaluated again at age 30, and they had a 3-fold higher risk of psychosis due to having used cannabis 5 or more times by age 16. So what's going on here? A lot of hypotheses going back to the dopamine pathway. If you think about the developing brain, any substance used earlier in life is going to have a greater role on brain development because it's going to impact the development of various pathways. And so if you hyperexcite that dopamine pathway early on, you may potentiate it to be hyper excitable later in life. So is there causation here? That's what we're always looking for. And we can't conclude definitively. Again, we just don't have that kind of research yet. From a cross-sectional study of 7,000 adults in a Netherlands twin registry, so these were matched twins, the risk score for schizophrenia that was derived from a large genome-wide association meta-analysis accounted for no more than 0.5% of variance in lifetime use, frequency of use, quantity of use, and age at initiation of use. Now, the meaning here, the take-home is, or at least what the authors want us to conclude, is the increased prevalence of cannabis use by people with schizophrenia was unlikely due to some sort of shared genetic liability. So it's not like some gene here is predisposing to both schizophrenia and cannabis use simultaneously. And they are prompting us to at least acknowledge the possibility of causation. We do know that cannabis use among psychotic symptoms worsens positive symptoms. And I can attest to this kind of throughout clinical practice. And here, again, the dopamine pathway model makes sense. If those pathways are already on fire and you add more fuel, it's going to get worse. From 2016 systematic review meta-analysis of 24 longitudinal studies with over 16,000 participants, Scholler and co-authors discerned cannabis use was associated with increased relapse, recidivism, coming back to the hospital more, and worse positive symptoms. These are the hallucinations, the delusions, but not negative symptoms. Negative symptoms refer more to a decline in overall function, especially social and occupational, and glutton affect, social withdrawal, as well as poor overall level of functioning. In a 2-year-long prospective longitudinal study of 220 adults with first episode psychosis, the authors saw there's an increased risk of relapse with hospitalization during periods of cannabis use. So we're seeing cannabis use in folks who already have psychosis pretty much worsens everything. Positive symptoms, they're more likely to end up in the hospital. They're not going to function as well. So here, it looks like the data indicates all 3 of these statements apply. How about cannabis use and anxiety? High rates of cannabis use are associated with anxiety disorders. Among cannabis users, anxiety disorders are more common among men than women. Cannabis use acutely decreases anxiety levels for the majority of people, or all of the above. What are people saying?
One, four, 4, 2, 1.
All right, good times. I like the.
Yeah, they're rocking it. It appears that I'm not the only one that wants to ask questions of an addiction psychiatrist. 4, 4, 2, 1, 4.
That's awesome.
All right.
All right, we like it. So, cannabis use and anxiety disorders, surprise, really significant association. Here's a secondary analysis. It was actually kind of the same cohort we saw previously for the mood disorders. They had over 40,000 US adults, 2 to 3 times higher rates of lifetime cannabis use among patients with anxiety disorders versus those without. We got to ask the question, is this people trying to self-medicate, like they're anxious to begin with, so they smoke cannabis, or does it trigger anxiety? In a survey of 36,000 adults, the surveyors saw that among those who met diagnostic criteria for cannabis use disorder, again, just not just cannabis use, but the actual disorder, among women with cannabis use disorder, across the board, higher rates of anxiety, be it co-occurring specific phobia with cannabis use disorder, co-occurring generalized anxiety disorder, social phobia, panic disorder, still pretty high for men and higher in comparison to the general population. What drives this? Well, simply put, if you look at all-comer, at least Americans, on a whole, women have a higher prevalence of anxiety disorders. There are varying different hypotheses as to why, but this is well demonstrated throughout the literature. And so if at baseline, women are already at a higher risk, you mix in cannabis, both groups go higher, but women still have higher rates overall co-occurring with cannabis use. We do know, it's demonstrated in well-designed studies, that cannabis use acutely provokes anxiety in a lot of people. It's less than clear what happens with long-term use. From a US study, it was prospective, longitudinal, community-based, they didn't see any increased risk of developing an anxiety disorder among cannabis users. Now, this isn't folks with a use disorder, but just kind of really any sort of significant use. Versus in an Australian 15-year prospective longitudinal study of about 2,000 adolescents, they found that daily cannabis use during adolescence was associated with a 2.5-fold increased risk of anxiety disorder by the age of 29 years. Gotta acknowledge these are community-based surveys, and all sorts of bias is going to impact the results of these studies, and they're kind of naturalistic. It's like who's going to respond gets included. I would say we need to acknowledge that the divergence here really is based on age. And again, we're seeing, at least insofar as the association, it's much worse off for adolescents who are using cannabis versus adults when the onset of use begins in adolescence. So in this case, it is 1, high rates of cannabis use are associated with anxiety disorders. We addressed 2. And for 3, cannabis use, in fact, acutely can increase anxiety levels for a lot of people. How about cannabis use and PTSD? Significant association, and in particular, cannabis use can potentially worsen the severity, which is wild. And a brief aside, my mentor in training, Dr. Andy Saxon, who, if you ever go on to UpToDate, you look on anything, opioid use disorder, alcohol use disorder, he's the section editor. He's one of the first addiction psychiatrists. He started the field, was an internist in Seattle during kind of opioid epidemic 1.0 in the 1970s. And that got him enough engaged in addiction treatment that he went on, did a psychiatry residency, and just really an incredible physician in person. He went to Olympia, the state capital of Washington, to testify against a bill that made PTSD an indication for medical cannabis. This was before recreational cannabis in Washington. The bill passed, but he referred to literature like this that finds that there's a lot of comorbidity in rates of PTSD and cannabis use disorder, around 10%, way higher than we'd like to see. And a systematic review of 4 prospective longitudinal cohort studies of adults with PTSD found that prior month use of cannabis was associated with higher levels of PTSD symptoms over time. Say what you will about this just being association, not causation. I get it. What I can't wrap my head around is how PTSD could, by any reasonable medical rationale, qualify as a diagnosis that allows people to try and use cannabis to treat PTSD. How about cannabis use, OCD, and ADHD? Significant associations here for both. Study designs are very weak. For OCD, it was a household survey, literally knock, knock, or call. In Australia, they got 9,000, about a 20% prevalence of OCD among patients with cannabis use disorder versus just 2.4% among patients who were abstinent. For ADHD, saw in community surveys that up to a third comorbidity between ADHD and cannabis use. We'll acknowledge the self-medication hypothesis. And in acknowledging this, I'm going to say I am very deliberate about how I share this with patients and even loved ones, because the key qualifier here is the amount of THC we're talking about is less than the standard joint and way less than most people with cannabis use disorder consume on a daily basis. Cooper and co-authors in 2017, in a British study in which they had access to medical cannabis and derivatives, and they could use specifically very, very tightly controlled, measured THC doses. They took a total cohort of only 30 patients, roughly 15 of whom were diagnosed with ADHD and 15 of whom were not. And they had them do quantitative cognitive testing pre-cannabis and also give a subjective report of how they were feeling insofar as their ability to pay attention and get things done. Then they gave them all 3 milligrams of THC, and they repeated that, I think it was a few days. So not a big N here, 30 total. What was impressive is they saw no statistically significant decrease in cognitive function by the quantitative measures in the cohort with ADHD. So the ADHD cohort with cannabis did not perform any worse on any sort of the cognitive testing, versus the control group without ADHD did perform worse. That's exactly what we'd expect. There was no improvement, however, in performance with cannabis. Interestingly, on the subjective report, those folks with ADHD said they thought they were doing better versus those without ADHD said, no, I'm under the influence of THC. This is not going well. What's relevant here? The dose was 3 milligrams. Again, average joint is probably at least 5 milligrams and going up with the trend of increasing THC concentration. And we know it is well documented, well studied, thoroughly replicated. Using THC 5, 10, 15 milligrams impairs cognitive performance by any sort of respected measure. In this case, it was a very, very tightly controlled, moderate THC dose. And probably what's happening is, as an ADHD, there is a deficit in the striatum. That's part of the prefrontal cortex. There's a deficit in dopamine. Dopamine in that part of the brain really helps us focus, pay attention, and prescription stimulants ramp up dopamine levels in the striatum. That's why they're used to treat ADHD. Well, yeah, THC increases dopamine levels too. So maybe used at a very, very, very moderate dose, you do get increased dopamine release in the striatum. And that helps some. Now, granted, overall, across the entire cerebral cortex, ramped up dopamine is not good for cognition. At low doses, in people with ADHD, it seems to balance out. Again, this is not that clinically relevant because people at higher doses, even if they have ADHD, the global cognitive impairment is always going to win. And, oh, just discuss this. So we can go back to the slide if you want to see more details. How about other substance use? Significant associations here, weak study designs, but we see across the board, be it alcohol or other substance use disorders, very comorbid with cannabis use. From a US study of 36,000 adults, they saw that alcohol use disorder had a higher risk of cannabis use disorder with an odds ratio of 6, so 6-fold higher risk than the general population. Similar for stimulants, tobacco, other psychoactive substances, be it methamphetamine or MDMA, 6 to 16-fold more likely per community survey data. Acknowledging that, while significantly higher number of folks with cannabis use disorder who have opioid use disorder in comparison to the general population is not as outstandingly higher in comparison to these other co-occurring substance use disorders. So we have a quiz from SAMHSA. Out of every 10 people who use marijuana, how many will become addicted?
We've got 3, 3, 3, 3, another 3, another 3.
All right, so we got some concern about cannabis use and how many people are going to go on to have cannabis use disorder. And emphasizing again, cannabis use disorder is physiological dependence plus functional impairment across domains. That's the same diagnostic criteria for any substance use disorder. So it's 1, but 1 is 10%. That's pretty significant. So acknowledging how common cannabis use is, and I will readily acknowledge at some point in my life, I experimented with cannabis. And in saying that, fairly representative of a good part of Americans in my generation between, let's say, 30 and 50 years of age. The fact that 10% of people who use cannabis at any one time in their lives go on to have cannabis use disorder, it's wild. And it's really concerning because the availability of cannabis is incredible. It's exploding and it's hitting hard here. What are our takeaways? Can anyone say where this pic came from and the actor?
Gregory Peck from Mark Pisklitch again.
Awesome. Yeah, so this is Dr. Strangelove.
Same movie. All right.
Yeah, same movie. George C. Scott. I forget the name of the general. I think it's like Taggart or something. So overwhelming evidence for acute and long-term cognitive impairment associated with cannabis use. Significant association between cannabis use and mood disorders. Use is associated with worsened severity of mood episodes. It's unclear about the causal link though. High THC consumption is associated with both acute psychosis and increased lifetime risk of psychotic disorders. And it's associated with worse positive symptoms. The evidence here suggests a potential causal link, change in dopamine pathways that we touched on a few times. There's a significant association between cannabis use and anxiety disorders. Causal link here remains unclear. Acute use oftentimes worsens anxiety. We have less evidence insofar as what chronic use does long-term. Significant association between PTSD and cannabis use. Cannabis use potentially worsens symptom severity in PTSD, and significant associations between cannabis use and OCD, ADHD, and other substance use disorders. Noting here that these study designs that this data comes from are fairly weak. How pertinent is this to our patients, our loved ones, family members? So looking at this map, the dark green is every state in our nation where cannabis is recreationally legal, and retail sales are underway. The next shade of green, which Montana falls into, so cannabis is recreationally legal, but unless you're sourcing it elsewhere, maybe driving it in from Washington, good luck buying it without a quote unquote green card. Though that's about to change come 2022. And then we're seeing in the lighter green, this is where it's medically legal, but recreationally illegal. And then places including Texas and good part of the South have cannabis as entirely illegal, which is consistent with federal law. So that makes it over 230 million Americans live in a state where cannabis is at least available for quote unquote medicinal purposes. And over a third of Americans live in a state where cannabis is legal for recreational purposes. And this has resulted in a significant increase in use across virtually every patient population. In particular, and what's really concerning based on the data we saw insofar as increased lifetime risk of psychosis, as well as other non-substance use disorder and substance use disorder psychiatric comorbidities, a lot more use in youth in areas where cannabis is recreationally legal. And we saw from essentially a naturalistic study in Washington state that non-medical marijuana legislation predicted a higher level of likelihood of self-reported past year cannabis use among youth when they controlled for everything. Pretty compelling. So really the most vulnerable patients are going to see more cannabis. What can we do in communicating to patients and other people we care about what's at stake in their cannabis use? So the story behind this is always be wary when you're asked to go speak as somebody who's just going to comment on the evidence. This is when I was still at Billings Clinic, and the PR person said, "Hey, Bob, we need someone to talk about the evidence surrounding cannabis use, and we think you'd be perfect, and our CEO really can't comment on this, so why don't you go?" Next thing I know, I've got these signs behind me, and I'll say, I mean, I think from a medical perspective, less cannabis is better. That said, from a philosophical perspective, I'm somewhat ambivalent about what role we should have with laws in prohibiting cannabis use. Be that as it may, I was tasked with, okay, ready, set, go, what can you say and make it accessible? So we know that frequent THC use is associated with worse depression, worse anxiety, cognitive slowing. If someone has primary psychosis, it's going to make for more severe psychosis with more frequent episodes and worse symptoms. If somebody has a history of trauma, it's very likely they're going to have worse PTSD symptoms. In adolescent, child use is especially high risk. Treatment. What do we have that makes a difference? So by far and away, when it comes to cannabis use disorder, unlike some substance use disorders, in particular, the exact opposite would be opioid use disorder, in which the medications really are the foundation. In the case of cannabis use disorder, kind of similar to alcohol use disorder, the psychosocial interventions have the greatest therapeutic yield and make the greatest difference. So some of what we're going to do is contingency management, which is basically offering incentives and disincentives to help people cut back their use and ideally abstain, motivational enhancement therapy, and or cognitive behavioral therapy, really engaging patients about their negative automatic thoughts and maladaptive behaviors surrounding cannabis use so as to replace those negative automatic thoughts with more positive, oftentimes realistic automatic thoughts and more high-functioning behaviors that are more conducive to abstinence. When it comes to medications, we don't have a lot. What we do have is gabapentin, and the seminal study that supports its use in cannabis use disorder came from Barbara Mason. She's at the Scripps University of California, San Diego Research Institute. She's done a lot of study on gabapentin for not only cannabis, but also alcohol use disorder, and saw that in treating withdrawal symptoms from cannabis, gabapentin really helps. And that's in part because we know that cannabis, much less so than alcohol, but in a similar way, changes amounts in the brain between the inhibitory pathway of GABA as a neurotransmitter and the excitatory pathway of glutamate. And so gabapentin really helps the brain recover from that physiological dependence of sorts. And in doing so, because patients are less anxious, less likely to experience insomnia when they acutely stop cannabis use, it's going to help them succeed if they're motivated. They did look at using N-acetylcysteine to decrease cannabis use and cravings in adolescents. In an initial study, it looked like it had some promise, but it was not replicated. And here's the study of using gabapentin versus placebo. Placebo is here on the top. Gabapentin is this lower line here. In the gabapentin arm, they saw a statistically significant reduction in the reported grams of cannabis smoked per week, which was corroborated with this urinary biomarker. Worth noting, though, if you look across the board, look at what happens over this time. So across the interval, you're seeing a huge decrease in both arms of the study. And all of them were getting psychosocial interventions, chemical dependency counseling, engagement in mutual help groups like NA. So gabapentin can help, but again, the vast majority of the therapeutic yield here comes from motivation, because there was selection bias, or getting patients who are motivated, and engagement in all those psychosocial interventions. Lastly, when it comes to harm reduction, so harm reduction is finding a way to support and ideally support patients and ideally mitigate the risks associated with their substance use, acknowledging that their goal may be to continue use. So specific populations that are high risk are adolescents, people with already an existing psychiatric diagnosis, and people who have a family history of psychosis for the reasons we discussed. For these specific populations and across the board, given the evidence we just reviewed, we really want to decrease overall use, not only the frequency, but the amount consumed, limiting the time of day. In particular, is concerning if somebody's going to be operating heavy machinery. Limit the amount purchased at any time, and decrease the THC potency of the product people are using whenever possible. Trying to avoid synthetics and those concentrates, in particular the wax and the shatter, again, that have super high THC concentration. And I'm happy to share an anecdote about cannabis-induced psychosis, but do want to be mindful of time. I think we only have maybe 5 minutes left, and we may have some questions.
I think that they'd love to hear the anecdote.
Anecdote, okay.
You're rocking.
So when I was in residency at University of Washington Harborview, did see one case of overt cannabis-induced psychosis. It was super sad. A 20-year-old college student, a sophomore at Seattle University, was using wax and essentially getting the equivalent of about 100 milligrams of THC daily. And this was chronic use going on for at least 2 months. Became overtly psychotic, was having hallucinations with self-harm content, was delusional and very paranoid, and concerned that people were trying to kill him. And in his paranoid state, ended up enucleating himself. So he took out one of his eyes. He was first surgically hospitalized. We saw him as a consult service and then followed him onto the psychiatric unit once he was medically cleared. He did improve significantly with abstinence, which was ensured through hospitalization, and treating with high-dose antipsychotics. I did hear from a fellow resident about 2 years later. He went on, had pretty much overt schizophrenia, which begs the question, would that have happened regardless, just maybe at a later point in time? Did he have a high lifetime risk of schizophrenia, but may have been able to at least not decompensate so brutally had he not used that high THC potency product? It's unclear, but it's one of those scenarios where it's so visceral, simply put, to see somebody who's gouged his own eye out while psychotic, using, in many ways, a kind of a distinct a distinct substance, in that acknowledging people using these extracts and concentrates are getting oftentimes 20x the THC dose in comparison to a joint. So really concerning, again, given what we know about dopamine pathways and how THC increases dopamine activity.
So we had a question about how that compares to MDMA and kind of what some of the negative consequences to the brain might be for excess use of MDMA.
So MDMA, it functions differently in that in many ways it's a combination stimulant and hallucinogen. There's some, so I got to keep it focused for time. So there's a bunch of research out there now using hallucinogens for treatment of depression, anxiety, PTSD, and some substance use disorders. In particular, when it comes to psilocybin, some of the initial research coming out of Johns Hopkins is promising, but again, we're talking about really controlled use, not on the regular. When it comes to MDMA, with street names ecstasy, Molly, the concern here is it's like combining methamphetamine with other compounds that add to its hallucinogen properties. Very, very sporadic controlled use is unlikely to be deleterious. Very, very frequent use that we'll oftentimes see, especially like back in, rave scene kind of has died down, especially thanks to COVID, but when raves were going strong, people were using MDMA on the regular, they would see significant long-lasting cognitive impairment. Similar to methamphetamine, MDMA causes a catecholamine explosion, or at least a surge, in which you have ramped up dopamine, ramped up norepinephrine. So people get really activated. Unlike just what you see with methamphetamine, with MDMA, you also see a boost in serotonin levels. That combination of those neurotransmitters, when they're chronically elevated because of heavy routine use, it's really neurotoxic. The neurons essentially die because they're in this neurotransmitter soup, and you're going to get consequent cognitive impairment. You can certainly see psychosis triggered from MDMA. It's not nearly as likely as you're going to see with methamphetamine. Meth is a whole nother discussion, be happy to have. It's a really dangerous drug, but kind of similar, the central thing to think about when it comes to the pathway that is culprit, dopamine pathway, and substances that rev up dopamine can induce psychosis.
Right. This is excellent, Bob. Thank you so much. We've got other questions, but we're going to be mindful of time. And we do have a question of if you're willing to send out your slides.
Most definitely. Yeah, I'll convert them into a PDF and send them your way, Matt.
Yeah, send them straight to us, and then Tim will send those out to everybody. Thank you all so much for joining us. Next month on December 8th, we're going to have Dr. Holly Wilcox of Johns Hopkins University talking about youth suicide prevention and other mental health conditions. So, Bob, you're amazing.
Hey, Matt, thank you so much. Thank you, everyone. Have a good afternoon.